Thanks for listening to the Lunch and Learn with Dr. Barry, here to help educate, motivate, and put you on the right path to take control of your health through weekly discussions on topics in the medical field, public health arena, and in your community. And now your host, Dr. Barry.
Hey everyone, Dr. Barry here. On today's episode, we are going to be talking about high blood pressure. More in particular, we're going to be talking about some recent new guidelines that came out that has changed the landscape of what it means to even have high blood pressure. In today's show, I have enlisted the help of a friend of mine, a great board-certified practicing internist, Dr. Watson Ducotel, alumni of Nova Southeastern University, to kind of help me argue why I think these new guidelines are absolutely ridiculous and it's going to cause more harm than good in the long run. So, like always, if you want to take show notes, head over to drpierresblog.com/LLP048. Go to drpierresblog.com, search podcasts, and you'll find my most recent episode there as well. And I appreciate all of the guys' support. If you have not had a chance, go ahead and check out my last episode, episode 47, where I talked about affirmation and goal setting. It was greatly reviewed and a lot of great feedback from it. So again, if you have not checked that out, check episode 47, which is drpierresblog.com/LLP047. All right, again, I want to introduce an amazing guest, family friend. He's been a friend since medical school, and he's the co-owner of Healthy Bodies Medical and Dental Center. For my podcast listeners, if this is your first episode, or if you've been rocking with me, since episode 1, please, give a quick round of applause to Dr. Watson Ducotel.
Hi, hello, everyone.
All right. So, Dr. Ducatel, I gave a little quick bio, but can you, explain to the people who you are and, how you got to kind of where you're at right now?
Hello, everyone. My name is Dr. Watson Ducotel. I'm an internist in Tampa, Florida, and I'm so happy to be here with you all today discussing a topic that is very important to all of us. And like Dr. Pierre said earlier, we have been friends since medical school, and not only colleagues, but family friends. And we like to get together to discuss these very important issues that affect our patients, our family members, and others out there in the community.
So I want to kind of let the people in, what kind of started this episode, right? So of course we were having a discussion like we always have on the medical field. And very recently, some new guidelines came out about high blood pressure. And most importantly, they came out about re-diagnosing high blood pressure and giving them different criteria. And we kind of went on like a rant, y'all. Like I'm telling you, it was, we were both pretty spirited discussion in the same direction, right? In which it usually happens because we're just kind of one like that. And we both figure you know what, we got to talk about this on a podcast on the podcast, because if we're feeling this way, there's no way others aren't feeling that same ill. Would you agree with that, Dr. Ducotel?
I definitely would agree with that. Every time you have a major guideline, we know that there's going to be some controversy. There's going to be people on both sides and in between. But there comes a point when, the guidelines not only becomes controversial among us physicians, but then become controversial among patients. And this particular guideline, produced by the AHA and the ACC, definitely has had a significant impact on the perception or the attitudes and concerns from a patient's perspective. And I really didn't see this with the previous guidelines, particularly JNC8 and JNC7, which were the previous bodies who submitted or put out the guidelines for hypertension.
And I totally agree. I think this one is like struck home because of just the amount of practice changes that's going to have to occur because of this. And, and we'll give you guys a kind of like a quick rundown of exactly like what the guidelines happen, what, what's got us all in like a tiff in that regards, right? So again, if you need like a refresher course on high blood pressure, please go to episode 7, drpierresblog.com/LLP007. I give a nice little rundown on high blood pressure from the schematic standpoint, so you can kind of understand what it is in general. So this one's going to be a little bit more advanced. So we're going to kind of assume you know what high blood pressure is, or you at least heard of it. And if you're, listening to this podcast, the likelihood that you have not heard high blood pressure is low. I'm assuming.
And what you just said actually brought a big smile to my face, because I was just thinking as you were saying, patients, you have heard of high blood pressure, and perhaps what is high blood pressure. And certainly they know that it means something elevated because we're saying high. So it's higher than what it should be. But the number in which they choose to base that definition on is changing, and has changed so significantly, and there lies the confusion. So it definitely put a smile on my face when you said that.
It's maddening when we talk about it. So like we'll give you we'll talk about what the old guidelines were, what it meant to be, a person with high blood pressure before, and what it means now, and just how drastic the changes has been. So you guys, every time you go to the doctor, first thing you do before you actually see the doctor, the medical assistant is usually taking your blood pressure. That's something that I've never been to a doctor office where they're not taking your blood pressure. So when they get your numbers, it's a top number and it's a bottom number. Again, we don't have to be specific on what it is. Before, when you were quote unquote normal blood pressure, is when you had a number below 120 and below 80 for the bottom number. And when we start moving up that chain, right, when we start saying like, okay, you're no longer having normal blood pressure, now you're in the pre-hypertensive stage, pre-high blood pressure stage, that number was 120 to 139 for that top number. And if I was thinking about stage 1, that number was 140 to 159. And the reason why this is important, because I want you guys to kind of follow along, and me and Dr. Ducotel are really going to get into it, is as an internist, like we're actually both internists. Like I said, I've been following this brother for a while, right? So he went internist, I went internist. What it tells us, right, when you're on a different stage, lets us know what type of treatment it is. So that's why, when we get to like what they've done now is like kind of thrown like everyone, especially in our world that deals with primary care and deals with high blood pressure, kind of front and center, like out the wazoo, right? So we got stage 1, 140 to 159, that top number. And if you were above 160, if that number was above 160, you were quote stage 2. And again, like the higher you go up in stages, the different treatment options we have for you, the different types of medications we're supposed to use. So when you hear that, when you hear facts like 1 in 3 adults have high blood pressure, right? About 75 million in the United States. Like, what, Dr. Duca, did you realize the number was that high?
I didn't realize the exact number, but certainly would have guessed it was several millions. And just because the guidelines, the goalposts keep changing, and they are going lower each guideline, just about, with the exception being the last JNC 8 guidelines. So certainly the numbers of people who are considered hypertensive or having hypertension is increasing every time these guidelines are increasing, and it's increasing by orders of millions and millions of people overnight by putting out these guidelines.
And overnight is correct. Like, again, I'm still talking about the old guidelines. Old guidelines, we had about 75 million. That's with an M, y'all. 75 million people diagnosed with high blood pressure. Unfortunately, even though I said 75 million were diagnosed, only 50% of them were actually being controlled. And I can tell you, I did when I was doing outpatient medicine. That was one of the toughest things, to be able to diagnose a disease but not be able to actually take care of it. And in your office, like, do you run into those same like types of situations where you know what the person has, but like getting in control of what the person has is a different ballgame?
Yep, absolutely. All the time, we have patients come in with hypertension, and some of them can have extreme cases, and we put them on medical therapy, and we cannot get to go. We have to go kind of do extreme measures to keep their blood pressure and try to treat to those goals. But again, the goalposts are changing, and most of them, the trend is that they're getting lowered. So, in retrospect, looking at those patients if we thought getting those blood pressures to goals that we had in the past with the previous guidelines was difficult, it's going to be extremely difficult now that the goalposts have dropped even lower. So we'll see how all this actually plays out in clinical medicine. And one of the things I want to highlight for the people listening is that a lot of times in these studies, when you have these clinical studies where they're monitoring patients that involve in research, the conditions in which those patients find themselves in is a lot different than what we experience out here in clinical medicine in the real world, each of us. So we have to take that into consideration when we're thinking about these guidelines and how we're going to treat our patients.
And I'm actually glad you touched on that, because we were listening to a podcast that kind of talked about some of these new blood pressure guidelines. And ladies and gentlemen, I want to kind of give you the scenario of how they were measuring people's blood pressure. I want to give you the scenario that how they were measuring it. And then me and Dr. Ducatel are going to talk about like how it's usually measured in the actual real world. In these studies that they were looking for, that they were basing these guidelines off of, they had patients would go into a room, would be by themselves. They would stick their arm in a machine, an automated machine that took their blood pressure. And that's after they sat down quietly and relaxed for 5 minutes. Now, Dr. Ducatel, does that sound like a scenario that happens actually in I'm not going to say the real world, in our clinical world that we've seen so far?
Absolutely not. It's more like the patient arriving in your lobby, they're maybe 10 to 15 minutes late. It's 9 o'clock in the morning. They have to be to work at 9:30. So they're really rushing and hoping they can get out. Of course, they ran into traffic along the way and probably had a cup of coffee. And so now they're waiting in your lobby, and finally when you get them back, they're anxious because they see you and your lab coat, and perhaps you're going through some labs or have some other things to discuss with them. And you take their vitals, and it's been 5 minutes. However, that 5 minutes has not been in the optimal stress-free conditions that we find a lot of times in the clinical trials or the studies that they do. And really, because of the American lifestyle, it's very difficult for our patients and us providers, us physicians, to duplicate those type of conditions, because I will say it, real life, it's much different than what we find in clinical trials, where they kind of control the atmosphere.
Definitely. And I can tell you, when I was in outpatient medicine, patient would, just like Dr. Ducatel said, patient come in, they sit in the lobby. If it's slow, we can get them back there pretty quickly. But remember, in this study, that's actually a bad thing, right? They actually want you sitting there for 5 minutes, relaxed, right? I used to have a lot of patients, they're worried about work, they're worried about school. They just had a conversation on the phone. They was yelling at the husband, they were yelling at the wife. Now they're coming to do their blood pressure. And then, of course, my MA is the one giving the blood pressure. My MA is manually doing the blood pressure. These are factors that actually happen in real life that they aren't accounting for in these studies.
Yep, absolutely. Absolutely. And And we see it in our practices, myself in clinical medicine every single day. So we try our best to get to create conditions we know will put patients in the best position to give us the best, most accurate information regarding their blood pressure. But that is not always practical. And so we need to come up with better solutions to be able to get a more accurate picture as to what their blood pressure is really doing. Now, they have suggested for decades, home blood pressure monitoring is something that I encourage my patients to do as well, so that we can get a more accurate picture, because the thinking is that patients in their own environments away from the medical atmosphere we will probably get a more accurate picture as to what their blood pressure is. So in that effort to create a better atmosphere to get more accurate blood pressures, we're recommending home blood pressure monitoring. And that's nothing different. But we will see as, again, these guidelines continue to change the goalposts as to what's hypertension, what's normal, what's not normal, what's elevated, what needs to be treated. We will see how these other recommendations regarding the conditions in which patients take their blood pressure affect the outcomes.
I agree. And let's get into these recommendations now. I think we've teased them enough, so they want to kind of know like what's happening, right? So I'm gonna give a quick rundown of what it means to be a hypertensive and I don't like to say hypertensive because a lot of people don't know what hypertension is. I like to say high blood pressure. That's a little bit more layman's term for us. What it means to be a high blood pressure patient. Before, I told you if your numbers were below 120 and below 80, you were fine. If you were below 140, you were called pre-hypertensive. And these new guidelines, and again, this is one thing that stuck out like almost immediately. We are no longer calling patients pre-hypertensive, right? Like there is no longer a stage for pre-hypertension. Right. The second your number hits 130, you are now a hypertensive patient. You are now a patient who has high blood pressure. And that's stage 1. Before, it used to be stage 1 if you hit 140 to 159. So now between 130, 139, you are now stage 1 hypertensive patient. Stage 2 hypertensive patient is now over 140. Dr. Ducatel, how many of your patients walk into your office over 140?
Well, as internists, we see patients, that are mostly adults. So those patients 18 and older, and out of that population, majority of patients that actually come into office on a routine basis, it's probably those patients are over the age of 40. Mm-hmm. So in that population, of course, by those definitions, the overwhelmingly majority of patients that I see would have hypertension or high blood pressure. Wow. And that's where many of us are growing extremely concerned, because of the social, not only the medical impact that it has on our patients and us as physicians, but also the social impact, the mental impact that it has on all of us.
Now, I'm glad. I'm actually excited that you talked about that, because I think a lot of times, especially in medicine, especially when you're the physician, we classify our patients. You have high blood pressure, you have high cholesterol, you have this, right? But we never actually think about the mental toll of telling a person like, hey, now you have diabetes. Now you have high blood pressure. Like, can you kind of like expunge a little bit on what like the mental toll it may occur telling a patient now they have high blood pressure?
I mean, think about it. Like I said, most of these patients are in their 4th decade, their 5th decade. They're over the age of 50, a lot of them. So they've been around for a while, and they've seen these guidelines and doctors' definition of what high blood pressure is changed throughout the years. think back to the original, not the original, but the earlier kind of guidelines regarding hypertension. So like JNC4, where they classified a normal pressure as less than 140, and then they said, well, if you have blood pressure from 140 to 159, then that's borderline high blood pressure. And if you have blood pressure over 160, that's systolic high blood pressure, or isolated systolic hypertension is what we called it. And actually, that's when we were going into medical school, we were still learning that, isolated systolic hypertension as a diagnosis, and that being 160. And that was JNC4. And then JNC5 comes along, and they take a more try to take a more primary prevention standpoint. So let's try to capture those folks who may not have hypertension, but are at the same risk for cardiovascular disease. And so they came up with, terms like high normal hypertension, which was classified as 130 to 139. And then they added the three stages of hypertension. And this was the JNC, I believe it was 5, that came up with those. So the goalposts have moved throughout the years, and now it's at a low point. And so that is going to create anxiety. That is going to create depression in some folks, because imagine those who have made it to goal. They've made it to goal based on the current guideline or the previous guidelines. And now, based on the current guidelines, the new guidelines that came out, they're still hypertensive.
Mm-hmm.
So imagine how those patients are feeling. We just took away that feeling of success, that feeling of a good outcome when it comes to treating their high blood pressure. We just took it away, and we said now the bar is a little bit higher.
Yep.
So talk about winning a football game only to be told that the game didn't count, or whatever
I love it. I love it.
How would that make you feel? And so I think we're putting our patients in positions where we're going to raise their blood pressure due to the anxiety, the stress, the depression that they're getting because of this. I have never, in the years that I've been practicing medicine, seen patients so anxious as they are now since the release of these new guidelines.
And
I haven't seen it until now.
And that's so true, especially when you hit home where now when I used to have my patients and I got them under that 140 and they were chilling in that 130 to 140 range, and all of a sudden, I need to increase your medication, or I need you to do something different. Like they thought they did all that they were supposed to do, and now that isn't enough anymore. And
absolutely.
And I think that's I think that was so like concerning for me, like, because the second I saw that, and again, Dr. Ducatel knows I am a conspiracy theorist when it comes to these medical research and these clinical trials. I unfortunately do not trust a lot of them, and I have to give a special shout out to my public health background from Nova Southeastern University because of that. I went into public health when I got the degree. One of the things it made me question a lot of medical research. Like it really made me like look at it differently, because like I was trying to find out like what is the agenda behind all of a sudden. And again, these are some numbers, people. Before, when I remember I talked about how about 75 million people have high blood pressure now. Overnight, with these new guidelines, that number has ballooned to 100 million.
And more.
Exactly. And that's a low ball estimate, because when I say that 100 million people have high blood pressure, that's the ones we know about. So there's a lot of people who are walking around with high blood pressure, especially now. Oh my God, definitely now, who did not know they had high blood pressure before.
And what's the scary part is we're talking now about a lot of teenagers. Mm-hmm. Now we're going to be seeing a lot of teenagers are walking around with hypertension, high blood pressure because of goalposts. And you know, it doesn't take a lot to think about these things in a critical way. What are we really trying to say to our patients and our medical colleagues with guidelines that have an overall trend where the cutoff points in terms of where we diagnose them gets lower and lower? Mm-hmm. You know, it's easier for us to diagnose them with certain conditions. What are we saying to the public? What are we saying to our profession when we do that? And what does it all mean? And I think those questions have not been answered in a real way. And we cannot help but to think, what's the role of big corporate medicine, big pharmaceutical companies mm-hmm. in shaping the opinions of the makers of the guidelines? We know that the American Heart Association, the ACC, while maybe not on an organization level, but many of its members are closely aligned with the pharmaceutical companies, oh, yes. or they participate in these research studies. You know, we're all human, and we have to assume that there's some biasness there. But what you talk about agenda, what is the agenda of these folks who are setting these guidelines? And how are they measuring the outcomes based on these guidelines? Those questions have not yet been made really clear to the public. And I believe if we had answers to those questions, all of us will be able to decide really better for ourselves what we want to do with our patients, and patients will be able to decide, you know, what risks they want to take in terms of treatment for hypertension or high blood pressure.
And I'll play devil's advocate, right? I'll play devil's advocate because I read their comments too. I read the people who are, for some reason, in support of this. They say, well, Dr. Ducatel, we're not saying that you have to start treating people at 130. We're just saying that maybe that's when you can start recommending lifestyle management a little bit more aggressively. And if they're low risk, you don't necessarily have to treat. But if they are a high risk, then we think you should treat them. Like, what would you say to someone with that argument?
Well, the argument, and I understand that argument, it's all in the way we structure and frame things. Like I said, the previous guidelines, when you go back to high blood pressure guidelines, and we can probably go all the way back to the original JNC 1 or the first version of it, and see what those guidelines were. But certainly you can see, if you look at the guidelines regarding high blood pressure, you can see the overall trend. You can see where they have define what is high blood pressure. They've gone lower and lower and lower. And in certain guidelines, they've labeled, they've used terms like high normal. They've used terms like pre-hypertension. Mm-hmm. And those terms came about because they were trying to do exactly what you suggested. They're trying to put out there that they're really interested in primary prevention, that they're trying to prevent patients from developing potential complications or in organ damage due to elevated blood pressure. But why don't we just do that? Why don't we just sit with that? Why do we need a lower definition of what high blood pressure is?
Yep.
Because psychologically, when you tell someone that they now have a disease and a illness versus you're at risk for a disease and an illness, you know, that's a difference to people.
Definitely. Almost definitely.
And it has an impact. And, you know, and so we really need to be
patients. I remember patients walking out my office, walking in with no diseases because maybe they haven't seen a doctor in a while. And all of a sudden I'm saying, all right, now you have high blood pressure and you have high cholesterol. Take this medication. Like mentally, it does something to them. It does something to a person to have to wake up and take a pill that they may not. And I think this is like, I tend to call hypertension a silent killer. They may not feel a single effect from taking that medication, right? Like they take their blood pressure medication, they don't feel no different. They take the high cholesterol, they may not feel any different. So now you're saying, hey, I want you to take a pill that you're probably not going to notice any difference for like a long time. Like you're probably like, especially if you're continuously taking, you're never probably going to feel different whatsoever. You may feel bad, like you may get some ill effects from the medication, but as far as me, lowering your blood pressure, you may not even notice that the pill is even working.
Yeah, absolutely. And we see that all the time. See that all the time.
And honestly, I feel like, again, I'm a conspiracy theorist when it comes to these things. I think a lot of it is an overreaction to failed treatment in the past. I think our medical society did such a bad job as far as educating patients and stressing the importance of taking care of your blood pressure. And now that they're on this like kick to try to prevent because they realize how much money it's costing them. Now that they're on this prevention kick, now they're trying to prevent everything.
Right.
Like, right. I mean, it wouldn't shock me if I turned around and all of a sudden they said, for you to be a diabetic, your A1C now can be as low as 6. Like, it wouldn't shock me if I turned around and saw that.
Right. And so we saw that with the cholesterol guidelines as well, that they're changing. In fact, I think the last guidelines was really big on not getting to a specific number because there was not a sufficient amount of evidence to suggest that we should be treating to exact numbers. Mm-hmm. So,
and I'll segue because me and Dr. Ducatel actually talked about like the cholesterol thing probably like 6 years ago. Like 5-6 years ago, we were looking at it like, what's the point of really chasing an LDL down to 100 or 70? Like, what does that actually like do, like in the grand scheme of things?
and you're absolutely right. And I remember being in medical school and going back and forth with the professor as to what would the future be in terms of how we look at lipids and things like that, high cholesterol. Because we were treating to these very specific numbers as if a certain number was going to guarantee to our patients that they would not have heart attack, stroke, and other complications that are associated with elevated cholesterol. So, and we found again, and then years later, they come out with the evidence saying that there's not enough evidence to suggest that we should be treating to exact numbers, and hence, the latest guidelines and recommendations on lipid therapy does not specify an exact number.
Nope.
So I think the same thing with blood pressure. Here's what I know we know. When we have those very ill patients that we take care of in the hospital, we're very concerned. Maybe we're taking care of them in the ICU. We're very concerned about their blood pressure because we know if their blood pressure gets too low, they could die. That is a fact. The fact of the matter is we need a certain level of blood pressure to live, to circulate blood throughout our bodies. And every single person could have a specific threshold, specific to their bodies, specific to the illnesses and diseases that they may already have. Now, the current guidelines that was just released does talk about risk factors, taking in consideration risk factors when it comes to hypertension or diagnosing hypertension or treating for it. That is nothing new when you look back at the J&C guidelines. That, kind of the suggestion that we should be taking a look at one's cardiovascular risk when determining whether or not we're going to start treatment. That approach is not new, but it's more present in the current guidelines. It's more flavorful. That's how I would describe it. And so they're suggesting that we use the recent cardiovascular atherosclerotic calculator that was suggested in the current cholesterol guidelines. They're suggesting that we use that type of calculator to stratify patients based off of risk. And if they have, for example, more than 10% risk in the next 10 years of major cardiovascular disease complications, then those are people that we definitely need to start on high blood pressure medicines. So taking that type of approach, but that's nothing new. And I think that's more fair than treating to exact numbers, because the numbers are changing. And we have researchers that argue and will continue to argue, what is the best number? The fact of the matter is, this thing is on a continuum. In one circumstances, if a patient's very ill, we may want their blood pressure to be very high. If a patient is not in that particular medical circumstances where they're very ill, we may want their blood pressure to be lower. So I think we need to take a hard look at how we are diagnosing people with high blood pressure and how we are deciding to treat them, because it is having profound implications and effects on my patients, especially since the release of the new high blood pressure guidelines.
And for those who may want to know what are like the risk factors that they're kind of referring to, gender is one. So whether you're male or female, race is another, and race is interesting because Dr. Ducatel would tell you he has some very interesting critiques in regards to medicine and race. And what I'll do is I'm going to link in the show notes an essay that he actually wrote on the website for me about that. So very, very interesting critiques, and I highly suggest you read that post, especially whenever you hear certain medications are better for blacks versus whites versus whenever you hear stuff like that. Dr. Ducatel goes into great detail to kind of tell you why you should raise like an eyebrow to that. Cholesterol level is another one. The systolic blood pressure, which is that top number we've been talking about today. Whether you're a diabetic or not plays a factor in this calculation. Whether you're on blood pressure medications prior, to like doing this calculator. Whether you're a smoker, and if you've been listening to the podcast, you know that I'm still trying to figure out why people are still smoking. Like, I don't know what more we got to tell you about cigarette smoking, about it being bad, right? Like, I don't know. I honestly don't know what more I have to say. If you're still smoking cigarettes, I mean, God bless, because, that's all I can say. Whether you're on
and I would just say one thing that's funny about smoking. What I've realized is, if it's legal, people assume it's okay.
Oh, yeah.
And that's that I want to be clear. That's not an argument to ban or make it illegal to smoke tobacco. I'm just saying, when people say, hey, Dr. Ducotel, it's legal, it must be okay. It must be all right. But if it was killing folks, they would outlaw it. I get that.
If they only honestly,
I get that. I tell, and the way I respond is, hey, food is legal, but if we eat too much of it, we know it could destroy our health. So what do you want? Do you want good health?
That's it.
Do you want good health? which is the most important asset that each of us has, that it gives us the ability to experience and enjoy everything, period. Everything. And without it, we cannot do it.
Yep, you're right. So, Dr. Ducotel, before we leave these great listeners with again, can you give some recommendations? Because now that they hear that all of a sudden I may have high blood pressure, and if you're one of my listeners who for some reason has not checked your blood pressure recently, please go to Publix, CVS, Walmart, or whatever grocery store or pharmacy that happens to be wherever you're listening to, and check your blood pressure. I'm almost shocked at the amount of people who don't check their blood pressure. But then I'm not, unfortunately.
Well, it's so much information out there in the age of the internet and Dr. Google, as I call them, or Dr. Wikipedia. It's so much information out there for patients. And so I think because we're bombarded with so much information, we just become used to it, and it's not as urgent to do certain things as it probably would have been if we did not have access to all this stuff, that's out there. So I agree with those recommendations. Every adult should have an internist or a personal physician that takes care of them, and they should know what their blood pressure is, so that if they have a blood pressure issue, they can get on top of it. And again, we know there's controversy with the current guidelines for high blood pressure. And I just want to say, we're not the only ones that are concerned about these guidelines.
Mm-hmm.
Many of my colleagues and many of your colleagues, Dr. Berry, are concerned about these guidelines. And patients and our other colleagues can just read the comments that have been made. Now, I don't want to make it seem like we're just bashing or just throwing out these recent guidelines, but I think it's fair to take a critical look at them to see how they're really affecting us, and to look at the overall trend on how that's going to affect our patients. We never want to be in a situation where we think we're doing good and we're really doing harm.
Ooh.
We used to give people mercury 100 and something years ago.
Oh, Lord.
But we were sure then that it was causing a benefit. We used to classify people with certain illnesses just because they're slaves. They used, the black slaves, they had medical illnesses that drapetomania and all these things. And these were real things that they wrote about in the medical literature. And here we are over 100 years ago, 100 years now in the future. And we know all that stuff was foolishness. So we want to be able to change and correct ourselves as a profession more quickly than we have been in the past. And that's why I think looking at these guidelines and others in a critical way, and instead of just accepting them as true, is much needed.
So, Dr. Ducotel, where can the listeners find you? Because obviously, when we bring guests on the show and, they give such great value like you've done tonight, where can they find you to be able to say, what, I like what Dr. Ducotel is talking about. I need to go where this guy's at.
Well, they can definitely find and like my company on Facebook. We started a healthcare company aimed at optimizing people's health. We're just not interested in giving you a prescription, getting you out the door. We want to sit down with you and figure out, what are your needs, what are your desires, what do you need done to get to your healthcare goals, And so we are called, the name of our practice, is Healthy Bodies Medical and Dental Center. We provide both medical and dental services. You can find
in the same building?
Absolutely. The mouth and the body is related. Your oral health and your physical health is related.
That's so true.
And so we're able to take an approach that encompasses both to improve your overall health, have a beautiful smile, feel great, look great, and is healthy in the inside. It's healthy in the inside. And so that's what we do at Healthy Bodies. People can find us on Facebook, Healthy Bodies MDC. They can also tune into several video blogs and posts that I put out there for patients to try to give them information about different healthcare matters. Like Dr. Pierre said earlier, I'm really interested in health and culture. And so that's my area of expertise in addition to public health and internal medicine. So I'm always willing to help. Patients can also, and the community can also reach out to me by email. They can email me if they have any questions at drwd@healthybodiesmdc.com. That's drwd@healthybodiesmdc.com. And if you're in the Tampa area and you want to be seen, you need an internist. You'd like someone to sit down with you, take their time, and get to know what you need and how you can improve your health, then you can visit our office, Healthy Bodies Medical and Dental Center.
I love it. And ladies and gentlemen, I tell you, this organization, Healthy Bodies Medical and Dental Center, it's such in the future in the way they're thinking. And it's going to get to a point where if you're in the outpatient realm and you're not trying to practice the whole complete picture, you're going to be left behind. So if you're in the Tampa area, you're near the Tampa area, and you need a physician, you need a dentist, like why wouldn't you want to go to the same exact building? You're not having to make separate appointments. You're not having to go across town. And these are, fine professionals. And I'm not saying it because, I know them, love them and everything. Like these are like fine professionals. Like they're absolutely amazing. So please make sure you reach out and hit all of the links that he's mentioned. Even if you didn't write it down and you're driving, you're in the shower, wherever you're listening to, I will put it in the show notes, and we're going to make sure, you follow along with Healthy Bodies Medical and Dental Center. And like I say, he does great.
One thing I want to add is our website, because I left that out. Our website is www.healthybodiesmdc.com. And so people can also visit our website if they just want to get general information about us and what we do, what we're interested in, and our center.
I love it.
I want to say,
and all of this again will definitely be in the show notes. Like again, I'm gonna make sure you find this guy. It's absolutely amazing. It's a treasure. I'm gonna put that essay in the show notes as well, so you can really see. Like, especially for my organizations that may be listening, and you want a dynamic speaker who speaks about health and culture, like this is the guy right here.
I appreciate that. And I just want to say, Dr. Barry, thank you so much for inviting me to participate on the podcast. I think what you're doing is definitely a service much needed out there in the community. It is rare that we get physicians to present the information with such honesty and from a patient's perspective, a true advocate for a patient. So I think that's very important, and definitely keep up the good work that you're doing here with the podcast and other things.
I so appreciate that. So ladies and gentlemen, that's episode 48. Again, like always, if you want the show notes, head over to drpiersblog.com/LLP048. And I'm going to see you guys next week. Thank you, Dr. Ducatel.
No problem.
Hey, Dr. Bear here. You have just listened to another great episode of the Lunch and Learn with Dr. Bear. I hope you're excited and hope you learned something from today's episode. I hope you learned from all of the episodes that you get a chance to listen to. Before you leave, if you not have already done so, go ahead and subscribe to the podcast. I am everywhere where you like to listen to podcasts at, whether it be Apple Podcasts, Google Play, SoundCloud, Stitcher Radio, iHeartRadio, wherever you like listening to podcasts. The Lunch and Learn with Dr. Barry is there. Also, go ahead and follow me on my social media outlets. I'm on Instagram, I'm on Facebook, as well as Twitter, all at Lunch Learn Pod, whether it be twitter.com/lunchlearnpod, facebook.com/lunchlearnpod, and instagram.com/lunchlearnpod, where you can, get any videos, any pictures I may post, any messages or writing. So please follow me on there. right after you go ahead and subscribe to the podcast, and right before you leave me a 5-star review on either Apple Podcasts or Stitcher Radio or wherever you can actually leave me a review. I'm much appreciative of all of you guys' support. And like I said earlier in the show, I will see you next week.